we're delighted to see you all here. My name is Deborah Jensen. I'm in Romance Studies and also at DGHI. And we have some very exciting visitors at Duke today. We have Dr. Eric Mintz from the CDC, and we have Sydney Mintz, the anthropologist Sydney Mintz. And please note that there will be another event with Sydney Mintz and Eric Mintz this afternoon at the Haiti Lab, actually at the garage in FHI in Smith Warehouse at 4 o'clock. So you're welcome to attend that also. And I'm going, the format that we have settled on for today's event is that first I'm going to say a couple of words about how our connection with Eric Mintz came into being. And then I'm going to introduce Mike Merson and the relationship of his work to Eric Mintz's work. Eric Mintz will be giving a brief talk, and at the end of this session we will have a brief presentation from a Haiti Lab student, Jana Regan, on material that relates to what will have come up earlier. So in October of 2010, cholera broke out in Haiti. It remains at the moment the worst cholera epidemic globally. And I was just looking through my emails, and it was on October 28th that Mike Merson wrote to me and said, I saw that you've organized the roundtable on cholera. I did research on cholera in Bangladesh early in my career and will be interested to learn what you hear on the origin of the strains in Haiti. And that was the beginning of a long conversation with Mike Merson that quickly became also a conversation with Eric Mintz, and then, to my surprise and delight, with Sydney Mintz. Eric and I began to dialogue about his published work on cholera after we had published an op-ed from the Haiti Lab about the Haitian epidemic. And then I was thrilled to receive an email from someone who I had no idea was connected with Eric Mintz, from Sydney Mintz, asking about what this suggested about the movement of populations in Haiti's history as well as the current moment. So the Haiti Lab began a fairly extensive research project on cholera, working with Victoria Szabo. We were teaching a class together on representations of Haiti that became much more a sort of history of global illnesses kind of class. And we eventually were, with Eric's help, able to publish a Haiti Lab article with our students in emerging infectious diseases, and I'm going to pass around a copy of this issue, which has work by Eric as well. And it has all been a fascinating experience, and we hope in Haiti circles at Duke to continue cholera research and health initiatives. So let me just say a little bit about Mike Merson and about his work on cholera. As many of you know, Mike Merson wears many hats at Duke, directing DGHI, the Office of Global Strategy and Programs, Vice Chancellor for the Duke National University of Singapore, etc. What people may not know is that he began working for the CDC on cholera and worked in the Cholera Research Laboratory in Dhaka, Bangladesh. And so his research in the early adventurous phases of a long and adventurous career focused on the etiology and epidemiology of acute diarrheal diseases, including cholera. And he then went on to the World Health Organization, then to the Yale University School of Medicine as the Dean of Public Health. And as you all know, he has now ushered in a new global health major at Duke, which we are hoping will really sort of revolutionize what liberal arts is becoming in this millennium. So Mike is going to say a few words and then introduce Eric, and we will get our conversation.
Okay, well, thank you very much. very kind words. Sort of ironic, I was just talking to Eric, who I've not met, but an individual that I hired at CDC and then became my deputy hired Eric. So you see, it's all one world, that we're all connected somehow in the world of cholera. I think what's so fascinating to me, and I'll tell you a few stories. What's so fascinating to me is how much cholera has affected many aspects of public health and even beyond, even literature. It's a disease that is perfect for the humanists, I think, in many ways. I'll just tell you 3 stories in my life that show you what cholera did as a disease. Just I thought about this morning, thinking back over 30 years ago. So I was running the enteric diseases branch, and at the time we were just talking about what that meant, right? In those days, and I was asked to go to Guam. How many of you know where Guam is? Guam is far. It's where America's day begins. Did you know that? And I went there because we got a call from the state health department that it's a protectorate, right? It's not really a state. That they had some very sick and one death from diarrheal disease, and what they, believe it or not, thought could be cholera. Now, Eric, I can't remember in 1974, but I don't think cholera had touched U.S. soil in maybe 30, 40 years at that time. And so it was really scary that cholera had arrived in the United States. I went out there, in those days you took many flights to get to Guam. And turned out, and I was looking at the paper today that we published, that it turned out we found 6 cases of cholera. And one died, and we did some investigation, and the best we could tell is that they had gotten sick by eating raw fish that had been caught in the bay outside Guam, called Agana Bay. Turned out that Guam then went on to have years and years of cholera, as I know, but at that time this was news, and it turned out they were finding cholera in the sewage system, and they found it in the river emptying into the bay. And no one really knew how it got into the country. There was the theory that the ships from Africa had been dumping sewage off the bay, and maybe there had been contamination of the fish, and the fish had gotten, had been caught and eaten raw, and that's maybe how these people got sick. So that was really, I think rekindled at CDC an interest in cholera, which it had more or less, it had still been there, but it never thought it would be on U.S. soil. So that was a scary moment for CDC. Little parenthetical, a year later I was still working at CDC, and I got a call from, and it shows you how cholera can affect someone's life. I got a call from the director of CDC. I was eating at the Pleasant Peasant restaurant in downtown Atlanta at 11 o'clock at night, and I got a call from the director to come to his office. This is 11 o'clock at night, and he hands me a ticket to go back to Guam. And I said, what are you sending me back to Guam? He said, well, there will be 300,000 refugees coming from South Vietnam within the next 24 hours, and we need someone to go and take care of those 300,000 refugees. This was the end of the Vietnam War. And I said, I don't know anything about settling 300,000 refugees. And he said, yeah, but you know Guam. And so there I was, heading off to Guam the next morning, and spent 2 months there, got to know every bit of the island, settling 300,000 South Vietnamese refugees, and learned a lot about refugees' health. I was coordinating the Army, Navy, and Air Force, and that alone in those days was a real challenge. The head of the mission was Admiral Morrison from the Navy. He turned out to be Jimmy Morrison and the Doris' father. And he was someone I could talk with. So that's my first cholera story. It not only was cholera to the U.S., but it turned out, at least for my life, to have me lead at an age of 28 the whole settling of 300,000 Vietnamese refugees from South Vietnam at the end of the war. I should tell you, a number of those families have come and found me and talked to me. They all settled well in the States, and that's a whole other story I could tell you. and they did very well. Second story, which may surprise you, in 1974, I got a call from, we had a call that there was very serious cholera-like disease in Portugal. And one of my deputy, I thought, Portugal, we better send somebody quite senior. So my deputy, Paul Blake, who turned out to be the person who I mentioned earlier, he went over to Portugal and to examine these cases of cholera that were occurring in Portugal. And he called me up after about 3 days, and he said, "You won't believe this, but we think the cholera." Everybody thought the cholera was coming from eating raw oysters, which is a common source of many different diseases. And he said, "You won't believe this, but I'm going to a spa tomorrow." I said, "You're going to a spa? Why are you going to a spa?" He said, "Because it sounds crazy, but we think these people really got sick from bottled water coming from a spa." I said, "Bottled water?" They said, "Yes." I said, "How can bottled water give people cholera?" Turned out, he did a beautiful epidemiological study, and indeed it was the bottled water that was giving thousands of people cholera in Portugal. And the interesting story there is it was bottled water that wasn't carbonated. And so that revolutionized in one swoop the way we thought about bottled water. Because today we tell people you should only drink bottled water that's carbonated because it brings the pH below 4.5 and nothing can live, I don't think much can live in pH below 4.5. So there's a second story on how cholera changed the way we think of just something like bottled water. Now this, of course, is not. But it did change the way people think about bottling of water. And then the third story I'll tell you, which is actually more substantive. So probably many of you know that the case fatality rate of the kind you've seen in Haiti was even higher in many parts of the world. And that was because back in the past, we used to treat cholera and other diarrheal diseases intravenously. And we used to think that you had to treat diarrheal disease, replace the fluids and the salt intravenously through the veins. And one of the main reasons we thought that was because we had this idea, which the pediatricians deeply believed, that the bowel was sick. And so the last thing you want to do is try to rehydrate somebody orally, and God forbid give them food, because their bowel was sick, they couldn't absorb it. So there were some very, very important studies done in cholera patients in the Philippines initially, but other studies done in India and then in Bangladesh. You probably have read about them. There are some people alive who did some of those studies, which showed that in fact, during cholera and almost any other diarrheal diseases, you can absorb. Yes, the bowel is sick, but it's sick in a few places. It's not uniformly sick. So in fact, you can rehydrate people who are dehydrated orally. The salt is absorbed, and in fact, you can feed them. Most of the food is absorbed. Now they may get a little increase in their diarrhea, but the food is absorbed. So those experiments revolutionized how we treat children, particularly children with diarrhea. And so you had a whole movement come about, and the best demonstration of this was in the early 1970s in the war between, well, at that time it was Pakistan, I guess, and India. There was a terrible cholera, and one fellow who's still alive named Dilip Mahalanobis went out with these oral rehydration salt packets and saved thousands and thousands of lives because there were no intravenous fluids. And it was the clearest demonstration ever that you could save thousands and thousands of lives of cholera by treating orally. So the treatment of cholera revolutionized the way we treat diarrheal disease. And today, finally, when I went to Geneva, I ran the diarrheal disease control program, and for the first 10 years, all we did was battle pediatricians who couldn't believe you could treat people. Now, of course, if someone is dehydrated and in shock, it can't swallow, you have to give them fluids intravenously, sure. Those are a small percent, and what happened in Haiti, I don't really know why the case fatality rate was so high. I've talked to Olivier Fontaine and people in Geneva who are concerned about the way the cases were initially managed, but I don't really know what happened. But we never, when I worked in Bangladesh, we used to treat 1,000 patients a day. We had a case fatality rate of less than 1% of the most severe cases. But we were very ready for it, and we had the best possible treatment facilities you could have. If people made it to us, we saved them. So I think the message I want to give you on this is cholera here played a revolutionary way of how we thought about people who are sick with diarrhea and how we would save them and treat them. Just one last note, which I really attribute to a lot of the stimulus of cholera. So in the need to treat people, a cholera patient, I think the first time I saw a cholera patient, they're so sick so quickly. The speed at which they get sick is just beyond your imagination if you've never seen them have so much diarrhea in such a short period of time. It's dramatic is the word I would use. And then to see that by doing this orally you could save so many lives was just a profound impact and led the world to create something called the Diarrheal Disease Control Program, which I was privileged to run in WHO from 1980 to 1990. And I was just in Geneva last week for a meeting, and in 1980 we wrote a paper that there were 5 million deaths a year from diarrheal disease in the world. 5 million. Now, not all cholera. There were 5 million total deaths. Right now, the maximum number that we think is 800,000. That's a drop of over 80% since 1980 in kids, in people dying from diarrheal disease. Now, not all of that is cholera. But the point I want to make is that because of cholera, we came up with an approach to treating diarrheal disease, oral rehydration, and food, avoiding malnutrition or preventing malnutrition, worse malnutrition. So it's a disease that I would say whether it helped me know what Guam was like so we could take care of refugees, or it changed the way we think about bottled water, or it revolutionized the whole treatment of a very serious problem in kids. It's been a disease that has a very important history. So I'll set some context for Haiti by telling you those little vignettes. Hope that's helpful.
Well, thank you, Mike.
Sure.
Another person who we both know at CDC, and is still very active, is Jean Gangarosa. And my introduction to cholera came in 1991 when, as was the case for Mike, cholera returned to the Americas, to the New World, in this case, to Peru, in January of 1991, and I was given a ticket.
Can you all hear Dr. Mintz? Yes?
Am I talking loud
You
enough?
might speak slowly.
Thank you. I was given a ticket and told that I would be going to Peru to work on cholera, and it was a great honor. And we spent something like 6 weeks there, did a number of investigations. I can tell you more about those. But when I returned to CDC and we gave our debriefing to the audience of the leadership, a little old man came to the microphone to ask a question. He complimented us and he said, "Thank you, very nice presentation. I've been a student of cholera for many years." I didn't recognize him. And I said, "Who is this old man who's been a student of cholera for many years?" And now, being something of an old man myself, I can say the same thing. I've been a student of cholera for many years, about 2 decades, a little bit more. And cholera has been a great teacher for me, and I think for humankind in general. It taught us, as the title refers to, about the importance of water and sanitation in disease transmission. In John Snow's time, the prevailing theory was that cholera was caused by a miasma, bad air. The bad air was evident to everybody living in London at that time, and it was easy to understand why the association with bad air was subscribed to. No one had, the germ theory at that point was not well accepted, and John Snow was able, by talking to people with cholera and people who did not have cholera, and really the first applied epidemiology, going out, collecting information on people who were ill and people who were well, and comparing the two, was able to deduce that the cholera was being spread by water, and was able to convince the authorities, against many objections, to remove the handle from the Broad Street pump. The cholera epidemic that was occurring at that time ended dramatically. There's a great book about this that you may want to read. It's called The Ghost Map, and it's very entertaining and goes into a lot of the many aspects of cholera, but also into John Snow's work. And we'll hear a little more about John Snow's work and its impact in the Americas from Jan. So, as Mike mentioned, cholera also taught us about, I guess, globalization and the movement of diseases and how that can happen unexpectedly. It taught us about oral rehydration therapy, which has been called the greatest therapeutic advance ever in terms of the number of lives saved. And as Mike said, the number of deaths due to diarrheal diseases has dropped from 5 million to less than 1 million over the course of about 40 years or so since oral rehydration treatment was developed and promoted. And that's despite the fact that there are a great many more people, and particularly children, who are especially vulnerable to dying from diarrheal diseases today than there were then. So the rate of death from diarrheal diseases has dropped even more because we haven't done as well with preventing a child from catching or getting a diarrheal disease as we've done at treating it. So we're lagging behind. There's a lot more work to do. John Snow turned 200 years old on March 15th, is probably still waiting for us to go out there and remove a few more pump handles. Cholera also helped. It was the disease that prompted the creation of surveillance, quarantine, boards of health, and New York City. In New York City first. Proud as a New York resident to mention that. And also the ICD, the International Classification of Diseases, which a few of you may be familiar with, and it's disease number 1 in that classification. So those are all core public health functions, and the sanitary revolution, the removal of pumps or pump handles, and the installation of water treatment systems, sanitation systems, hygiene, and shellfish safety, as you mentioned. But all of those public health actions were driven by cholera, and they helped reduce cholera, but they also had much broader impacts on diarrheal diseases, on waterborne and foodborne diseases in general.
Maybe you should say a few words how CDC is organized your work, how you fit in, how CDC is done. It might be interesting.
If that's of interest, I could say more than a few words, but I won't. CDC is an agency of the U.S. government. It's part of the Department of Health and Human Services. It has a very broad focus on public health. It has no regulatory authority. We're not the EPA, the FDA. We're not WHO, so we are very careful to work closely with ministries of health when we work overseas at their invitation. A lot of the work at CDC is focused on removing the pump handle equivalents of modern American society. There are a lot of pump handles. Humankind is quite inventive, and you can think about pump handles such as tobacco, sugar, high fat, high sugar, high salt diets, firearms. These are all contributors to disease transmission, and they are proving harder to introduce and to propagate than to remove in terms of preventing disability, death, and illness. So there are a lot of pump handles out there. Any of you who want to go remove one, there's plenty to choose from, even beyond cholera. So CDC does have a growing international presence, and a lot of that arose with the AIDS crisis and the recognition that responding to that overseas was a global security issue, was of use to the U.S. government for many reasons, not just protecting the health of U.S. citizens, but also diplomacy, etc. So we have been well supported to work on PEPFAR, the President's Emergency Plan for AIDS Relief, the President's Malaria Initiative. So while our international efforts used to be only of the type Mike mentioned, where a country would request assistance from CDC, either directly or through WHO, we now have a presence in 60 countries internationally, working on a broad array of diseases. Most of the funding and most of the work is around HIV/AIDS, malaria, immunizations, vaccine-preventable diseases. But there's a small and growing interest in diseases transmitted by water, food, which is what I've been working on. So I can tell you a little bit about my own little Jon Snow moment, which occurred in Peru, in lower case, when we had done a study very early in the epidemic, and we showed conclusively that the water sources people were drinking were contaminated. The city water was contaminated. This is quite common. The bottled water, in that case, we didn't show it was contaminated, but that has happened in other cases, and Mike's advice is well taken. When you're outside the U.S., you should try to avoid uncarbonated bottled water. Tea, coffee, and alcoholic beverages and carbonated beverages are unlikely to transmit cholera. So we had done this study and had shown that people who drank water that they didn't boil were more likely to get cholera than people who boiled their water and stored it safely. And we had shown that the water sources were contaminated in the laboratory, and we went back to the community where we did the study to explain this to them and to, give them those results so that they could protect themselves and their families from cholera. And it was spreading very quickly at that point. And they listened, and the president of the Mothers Club, who had helped facilitate the study, really need to work with community leadership, and she was one to be able to go door to door and ask questions and draw blood samples from people and collect their stool samples. You can't just show up and say, I'm from the U.S. government. We have some questions for you and want to take some samples. So she'd been very helpful the whole time, and she said she looked at us a little skeptically, and we were telling her that boiling water, storing it safely is really vital to the health of you and your families. And she said, well, boiling water is very expensive. It had been recommended before our study. We knew cholera. We've known a lot about cholera for a long time. And the Ministry of Health told everybody to boil their water, but not everybody was doing it. And the reasons were it's expensive. Fuel was expensive. It's time-consuming. And at the end of it, you've got a glass of hot water, which in a hot place like Peru isn't what you're thirsty for. So people were having a hard time adopting this, even though this was a new disease and a deadly one, and they recognized how important it was. They were having a hard time adopting and maintaining that behavior. And she said, well, she looked at us and she asked us, do you boil your water? And we looked at each other and said, oh, no, we don't boil our water. In addition to the plane ticket, before we left CDC, we got these little pills, iodine tablets, it turned out, and we put those in our water, and that makes it safe to drink. and so she looked at us and said, well, we could do that. And a small light bulb, a low wattage bulb, nothing like Jon Snow's, went on. And so for the next 20 years, and it's ongoing, we've worked to try and provide people with the means to treat their own water. And chlorination is one way. Filtration is another way. Solar disinfection. There are a number of affordable, practical technologies that can be produced or developed in country and marketed through the existing system, and socially marketed, distributed in emergencies that will work, that will protect people from cholera and also protect them from other waterborne diseases. And it's a growing movement. It's very exciting. It led us to explore all sorts of things that we hadn't learned about in medical school or in CDC training, such as engineering. How do you make these products affordably? Behavioral science. How do you get people to use them? Economics. How do you make it work in a sustainable fashion? No, clearly nobody can pay for all this to go on indefinitely. They're medium-term solutions. In many places, people don't have access to safe water, and there has been progress, but it's slow progress, and it will be many years before everybody enjoys the luxury that we take for granted of opening a bottle or turning on a tap and being able to drink something that won't kill them or their children. So until that long-term goal is achieved, this is a way we found that it helps respond to epidemics. I thank cholera, if you will, for helping us get involved in that. I think we've gone past 100 billion liters of water that people have treated in about 30 countries with the sort of products we've worked on. And it's growing. What's so exciting is the engineers, the economists, the behavioral scientists who are now involved have a lot of great ideas that we wouldn't have thought of. So I think in years to come we'll see all sorts of new things from a chemical and physical perspective that'll be adaptable to these situations, sort of like cell phones took off in development. So I could say more, but I don't want to exceed the time allotted.
Well, I think that is a perfect moment for a segue to a couple of things. Earlier, you were mentioning that in terms of cholera vaccinations, that one of the great ethical issues is, should you be investing in sanitation infrastructure, and will the availability of better cholera vaccines provide an easy way out for local or international government organizations to not address fundamental environmental threats? So, and it's the perfect moment to move to Jan's very brief presentation. So Jan is a student in the Haiti lab. She's an environmental studies major. And in the Haiti lab, we were working on the 19th century, reviewing digital journalism and other historical records of the extremely numerous cholera epidemics that just swept through virtually the entire Caribbean, with the apparent exception of Haiti in the 19th century. And Jan worked specifically on the question of how John Snow's work with the pump handle had impacted the 19th century Caribbean. And she will tell us a couple of things about her work, and you can follow up looking at her blog on the Haiti Lab website at NHI. So, Jan.
Thank you, Deborah. Hello, my name is Jana Regan. And in my research, I really wanted to answer the question of how John Snow's work in London with the Broad Street pump handle was applicable to the Caribbean, especially in the 19th century in the country of Cuba, when epidemics of cholera were occurring. So my research led me to analyze the work of Dr. Carlos Finlay, a Cuban physician at the time, and he had gone through John Snow's methodologies, and he applied it to the neighborhood of El Cerro in the city of Havana. And on this map, you can see El Cerro in the lower left-hand corner. Topographically, it's interesting. It's situated much higher than many of the other neighborhoods in Havana, and so Finlay knew, Dr. Carlos Finlay, he knew that cholera couldn't have really been introduced through rainfall, through flowing water, yet there was a major epidemic in this region. So to the left you see Rio de Almendares. That was the main water source to people in El Cerro, and the Spanish officials at the time had built an aqueduct connecting the Rio Almendares to El Cerro. And Finlay noticed in his research that the first few cases of cholera in this region came from workers on that aqueduct called La Zanja Real, the royal ditch, literally. They were transported to hospitals in El Cerro, and from there, the epidemic of cholera had spread. In another article that Finlay had published, he compared two groups of houses in El Cerro. One group had their main water source come from the Rio Almendares, the infected Zanja Real, and the other group had their water come from well water Not surprisingly, he found a majority of the cholera cases come from the houses that used water from Rio de Almendares. Within the first 12 days, there were more than 120 cases. So much like John Snow's public health recommendations at the time, Finlay had recommended that people wash their hands more frequently, that they avoid using water from La Zanja. So by 1872, cholera was eradicated in this region. And I thought it was interesting how two geographically completely different regions, Havana and London, could use similar analyses of research methods that John Snow had used to eradicate infectious diseases like cholera.
Thank you so much, Jan. And Jan's work has focused on Finlay's use of public media to clarify the debates around cholera transmission. So Finlay wrote op-eds to the newspapers. The community reacted with umbrage. People didn't believe what he was saying. And over the course of a number of months, the community debated it and eventually proceeded to take measures that helped with that epidemic. So I think now we can open things up for questions for Dr. Merson, Dr. Mintz, for Jan, for me, for Laurent, for anyone.
I want to ask a question.
Okay.
But anyway. Two questions. One, I was wondering, well, I mean, with these last two presentations made me think of the peculiar case in Haiti after cholera, of the kind of the huge controversy around the source, right, which is sort of still ongoing. And it's interesting how in Snow's case, or in this case, the whole point of identifying the source was a key epidemiological thing, whereas in Haiti, for all kinds of reasons, the kind of the politics around the source became such a vexed issue. And I don't know if you have insight about why that happened, because in some ways it still mystifies me why that has been so complicated, you know, and maybe you have insight into that. But the second is also about just carrying, you know, transporting and carrying water around. You know, in Haiti, people would use these little bags to sort of, and the whole question of how you circulate water to people who need it after the earthquake was a big deal. So treating water is one thing, but then actually distributing water in contexts where the infrastructure, the most efficient infrastructure, which would, you know, be piping and so forth, doesn't exist. So I wonder, because that seems like kind of a critical zone where, you know, how people kind of transport and store water seems key as the first stage of treating it. I don't know if you have any reactions to either of those.
I'll answer the second question first because it's the easiest one. You're probably going to have to remind me about that tough question, or maybe you'll forget. I'll get off the hook.
You can ignore the question if you want.
So you're absolutely right. So in many places, even where there is piped water, it's not piped water in the home, and it also may be piped but unsafe because of clandestine connections. We saw this in Peru. This is certainly prevalent all over the world, where the water supply that's piped isn't extended. The city grows, the piped water supply doesn't keep pace, and the water resources, the reservoirs, aren't sufficient to distribute water everywhere all the time. So it gets rationed. People connect to the pipes in Karachi and many other places where there's available and affordable technology. They connect to the pipes with little pumps because the water isn't coming out. You know, there's not enough pressure in there to get the water out, so you just suck it out. Of course, you're also sucking in everything next to the hole that your neighbor made upstream to connect his pump. So collecting the water, transporting the water, handling the water, and storing the water safely in the home are as important. Because even if you boil that water at home, it's then clean. If it's sitting in an open bucket, people are dipping cups in, and children are playing with it, and ladles, and animals are in and out of the house, that water won't stay clean. Chlorine is useful because it provides a residual chemical barrier, but that also is gone after a day or so. So safe storage containers are something we promote as well, and you can integrate the treatment and the storage container. For example, in a ceramic filter, a ceramic pot, a flower pot, the water flows through that. If it's coated with silver, that kills the bacteria, but the pot sits inside a bucket, and the bucket has a lid and a tap at the bottom. So having a container that allows people to take water out without putting anything in is an important part of the programs we're involved in. What was that trick?
First question was about
You were questioning something about Hologen, and I'm not sure. I can't remember the details.
Right. I'm not sure.
Yeah.
No, that was very cool.
I mean, I think we kind of understand why, but it's kind of like there's just, it's just so against the usual kind of practice of epidemiology where the whole priority is you identify the source and that helps you contain the disease, right? That's why I guess
that's and it's a valid question, and this is not by any means the first time. In fact, the real name of the bacteria that causes cholera is Vibrio cholera, subspecies politicus. You don't see that in medical textbooks, but it's inevitably. And the same thing happened in Peru, and the same thing happened in New York in the 1800s. Where did it come from? And often it's blamed on immigrants. That's right. Yes, that's sort of true. And in that episode about the bottled water, the part of the story didn't tell is that how did the water in this spa get contaminated with cholera? There weren't any oysters in the spa. And the answer, as best as could be established, and it was pretty conclusive, was that it was established because there was a base of soldiers, Portuguese soldiers, who had returned to Portugal. This was in the 70s, mid-70s, from Angola, where they were fighting on the wrong side of the war for independence. And cholera was endemic in Africa during the mid-70s, and they most likely picked it up there and contaminated the wonderful, healing spring that this spa was bottling and selling. And it was very paradoxical because, of course, once the epidemic in Portugal was detected, the ministry went out and told people, boil your water, but if you don't want to boil your water, drink bottled water. And so instead of ending the epidemic, the cases dramatically increased.
I can add that I think in the history of public health, there are a lot of examples of blaming the foreigner.
Yes.
And I think it's a really interesting, from the humanities standpoint, quite interesting. That look at HIV. Sure. I mean, with so many examples of blaming the foreigner, we can come up with 5. I mean, the peacekeeping troops. I remember when I ran the global program on AIDS. There was a big effort made by the African states. They didn't want any peacekeepers to come into their country unless they were screened for HIV. Because they were, and these were countries with prevalence rates of 20–25% in their own population, and they worried about HIV prevalence rates in peacekeepers from a low prevalence country. I mean, it was all because you needed to blame the foreigner that was bringing HIV in the country when there was already so much HIV in the country. But I think this is just unfortunately true, that there are just example after example of where the foreigner or the person from outside is to blame. It's politically convenient, but it's also maybe something about our human nature that you people in humanities can tell us about. I think it's to me quite fascinating how much the focus is so often on the outsider rather than on ourselves.
Although interestingly, in this case, the outsider, the
I know.
Nepalese UN forces,
there is
are associated with that
people's
power.
movement is part of a key
Right.
thing.
I know in this case it had some validity. I understand that. But most of the problem in Haiti that it spread was not due to the source was from the outside, but the problem was internal in terms of the water. The problem they had, including their high mortality rate, I would not blame on the United Nations.
Right.
Right. And there's no question that cholera could have gotten into Haiti from many different sources other than peacekeeping. I mean, I understand in this case it was peacekeeping, but you can imagine other people could have brought it in very easily.
A lot of my experience at CDC has been on foodborne outbreaks in the United States, and what you said about identifying the source so you can remove the source, as John Snow did, because it was the Broad Street pump in that instance that was contaminated, not all the water in London until later in the epidemic. So we do that, and that's the first thing you do. And in the situation in Haiti, by the time the first case was detected, it was already too late to remove the source. The source at that point was river water, the major river in Haiti, the Artibonite, and it's a big river, and it flows all the way to the sea, quite a distance from where the UN peacekeeping camp was, very quickly. And within days, there were cases all along the Artibonite River, particularly at the mouth, and where there's larger cities and a lot of rice cultivation and other activities involving contact with water, and people get their drinking water from the river. So identifying the source, it wouldn't have saved a life. It wouldn't have prevented an illness. It wouldn't have had a significant impact on the epidemic.
That's the point.
And so, had the epidemic been over, well, we would have focused our investigation on the source, because maybe it could come back to whatever that source was. Exactly. But the epidemic, as we had predicted, was like a wildfire out of control. Because, as Mike mentioned, the population coverage in Haiti of water, safe water and sanitation is abominable, lower than anywhere in the Western Hemisphere, lower than most countries in Asia and in Africa. It's really very poor. And we knew in 1991, in the Latin American epidemic, we looked at the Caribbean, and we were very concerned it would spread to the Caribbean. And when we looked at countries that had cholera, this was 5 years into the epidemic, we saw that the countries that had the highest infant mortality rate, which is kind of a proxy for water and sanitation, had not, they were cholera introduced, and they had a heavy burden, persistent, many cases. And the countries like Costa Rica, for example, that had very low infant mortality rates, cholera was introduced, didn't spread. It was no cases after the first year or two. And we looked at Haiti and the Caribbean, the rest of the Caribbean, on that curve. And, the worst countries in Latin America were Bolivia, had very high burden, Peru, etc. Haiti was out there, and the infant mortality was double what it was in the worst hit countries in Central and South America. So we knew it was going to be horrible. And as is its wont, cholera fooled us once again, and there were no cases in the Caribbean, no cases in Haiti. I guess we allowed ourselves to be lulled into a false sense of security. So we weren't directly involved in that investigation. It is an important investigation. I'm glad that other agencies undertook it. And in fact, some of the first results were published in the CDC journal.
Yeah.
I think the sadder story in Haiti is the 8% fatality rate. Right, to be honest with you.
Well, it's come down.
No, I mean the initial.
High. It was very high initially.
That's the sad part.
And I think, that is still true. To me, you see that in cholera epidemics in places that have never seen cholera before. They don't know what cholera is. There's a lack
surprise
of...
Yeah.
That's right. People, they have diarrhea. They're adults.
And they
they're
think
not
it's
going to
like
die.
some other thing that is not as dangerous.
That's right. And the clinicians, I don't know what diarrhea, well...
Right.
And the patient's dead by the time they realize how severe it is. So there's a lot of effort we did in the beginning, rather than investigation, the source, to train the community and the healthcare workers.
Good. Can you just comment on sort of the current state of vaccination for cholera? I was in Bangladesh last year, ICU therapy, not in cholera. They're running a big vaccine trial there, and can you comment on it in sort of the endemic setting as well as the epidemic? Can we really, does it really work in the epidemic? Resource-wise, does it work, vaccination? Because I used to really eradicate it completely, so should you just scrap the whole thing just to make sure that people get treated?
Yeah, I can comment. I can't give you a yes or no answer to that question, but it's certainly of great interest to everybody in the field. So cholera vaccines for cholera, they were one of the first things developed for a bacterial disease, first vaccines to be used in large-scale field trials, first vaccines to have efficacy studies, effectiveness studies done in trials. And this was in the 1800s, and the trial showed that it was not very effective. So they've kind of enjoyed a rather poor reputation since then. There was a cholera vaccine that worked about 50%. In other words, it protected half the people who got it. It had a very bad side effects profile. This was in the 50s and 60s, and anybody who got it will remember because the arms swelled up and it hurt, and you got a fever. And then there was only 6 months of protection if you were the person who got protection, not the other one. So, crummy vaccine, and there were episodes where it was used to the detriment of people's health. And one example was from Egypt, where it was used to try and control an outbreak of cholera, but unfortunately they didn't change the needles, and an epidemic of hepatitis B followed. that campaign. So there was a lot of sort of bitterness and bad feelings about cholera vaccines until the 80s, when a newer vaccine was developed and tried in Bangladesh, landmark trial, and was effective, about 67% effective for a duration of about 2 to 3 years. It sort of dropped off towards the end, and it was less effective in children. But that was still far better than the other vaccine, and it was an oral vaccine. So you could drink it, you didn't have to inject it. It was not widely adopted, and I think part of the reason was the cost. It was marketed for travelers in many countries, sold briskly in parts of Europe, but wasn't adopted by the countries where cholera was endemic or caused epidemics. And part of the reason is it wasn't, part of it was the cost, part of the reason is that it required 2 doses 2 weeks apart, between 1 and 6 weeks apart. This is Duperol. It's still on the market. It's not licensed in the U.S., so if you want to get it, you have to go to Canada to get it there. They have recently, and the reason you're hearing more about cholera vaccine and the trial that's being done in Bangladesh, recently developed a similar but improved version of that. So you had to take Duperol with about this much water because it had a protein in it, and the water had to have a buffer in it to protect that protein from your stomach acidity. So that made it even harder to pour, and you needed 2 doses. Well, now they have a version that's just in a little vial and it's a few drops. Easily give it to a child or an infant, and you don't need the buffer. And that's great. You still do need 2 doses.
Is that the vaccine being used in Haiti?
It is, and it's called Shancol, and it's manufactured in India. So the Duperol is manufactured in Sweden. Guess which one is less expensive? Shancol is about a third of the price. It's still about $2 for the 2 doses of vaccine, and then you need to get it to the people, and you need to get it to them again because they need their second dose. So not ideal, not like measles vaccine, not like polio vaccine. It's not 100% effective. It doesn't last that long. So but it is an improvement, and it is cause for WHO and others to sort of reevaluate their recommendations. Endemic countries, it has been used in a targeted way in Vietnam and in China, where they have part of the country near a river where they always have cholera every year at the rainy season, and they've used the vaccine to prevent those seasonal epidemics. They're endemic countries, but it flares up. And as they were doing that, they improved the water and sanitation supply. In Vietnam, this is along the Mekong Delta, Mekong River in southern Vietnam. And they were able to stop vaccinating against cholera. It was also on the coast. And the cholera didn't return. So they had gotten to the level, and it's not the level we enjoy today. I mean, we got rid of cholera in the U.S. in the early 1900s, essentially, in Europe. You don't need this. You don't need hot and cold 24-hour running water everywhere. You just need, it's a pretty low barrier, so you need clean water available to all. They were able to do that in Vietnam and in these areas in China where the vaccine was used, and they no longer had cholera. So I think that's a strategy that everybody feels is rational and reasonable.
I would add one thing. I think the thing about vaccines that have moderate efficacy, any vaccine, 50-60%, is really a dilemma. Because if people have a false sense of security, that's worse than not taking the vaccine. So I think that's the issue for me with these intermediary vaccines has always been how to frame it for the public. And can you frame it for the public in a way that they'll get it? And understand that whether you take the vaccine or not, your habits have to be the same. Okay, this has come up a lot with HIV vaccine. You know, if you have a 50% HIV vaccine, which we may have soon, is that good or bad? What's that going to do? You know, so are people going to change their behavior? If so, that's not very good. So I think now if it's 80%, sure, we're getting into a whole new category. And if it's 20%, it's clear. It's this 50-60% that creates a real dilemma in public health. It's not just an ethical dilemma. It's really a public health dilemma as to whether or not we think we can get the message to people. Your behavior really shouldn't change. You should drink the same safe water, eat the same safe food, wash your hands, even though you have the vaccine. That's not people take Lipitor in this country and they eat all the fats they want. And they don't exercise because they want Lipitor. I mean, that's a crude example, but it's the #1 drug in America, right, in sales, is Lipitor. And that's why you see people eating. One reason is, 2/3 of men my age are popping Lipitor, so they eat what they want. So that's really the dilemma with a cholera vaccine.
And its use in a reactive, so during an outbreak, is very problematic. And people are doing a lot of, with Gates Foundation support, a lot of studies, a lot of different paths of inquiry to see, well, will it work? And how? What are the conditions when it should be used in a reactive manner? And what are the conditions that actually could do more harm? I mean, if you take all the doctors out of the hospital so they aren't treating patients, they're busy vaccinating people, that obviously is not appropriate in a big epidemic such as early in the epidemic in Haiti that would have meant. But now in Haiti it has been used in some pilot studies. They looked at the issue of behavior change, and they're planning to do more vaccination because it seems like cholera will be around for a while.
But the issue, I'll just add one more thing, the issue of responsibility for better sanitation goes along with that. In the 19th century, Karl Marx wrote that cholera was the revenge of the East on the West. In other words, there had been all of this military engagement in India, and now, cholera was in Western Europe. And he was one of many people who noted that nothing had compelled the British bourgeoisie to invest in the sanitary system until cholera. But cholera made it inevitable. They had to. It overcame, the divisiveness of class interests. And so how vaccines impact on that kind of decision, as many of you are aware, there has been a call for the UN to support the creation of sanitation infrastructure in Haiti, and these are big questions.
Yeah, I
got to run.
Okay, thanks so much.
Good to see you. Okay.
Yeah, that's right. We are.
But you keep going. I just got to run.
Okay.
Nice to see you.
One or two more questions.
I know in, for example, the cholera outbreak or incident, I guess, in, for example, Los Angeles in 1993, the CDC put a lot of legwork into identifying the origin of the outbreak down to a single person.
That's right.
And so I was wondering if you could talk a little bit about what are the circumstances that make the origin of a cholera epidemic an important part of the investigation, and what are the circumstances that make it marginal?
I'd say it's always an important part of the investigation, but when you have people dying, that's the important part of
so the CDC plans on following up on it now that the cholera epidemic is sort of...
Probably not. I think the evidence that other groups have accumulated is pretty comprehensive. I don't think there's more we could add, and I think, the UN has recognized, although not perhaps fully, that it's certainly compatible with the UN peacekeepers having introduced the disease, and that the sanitation conditions in the camp were not what they should have been. And they made a series of recommendations. They got a special committee to investigate this. The special committee made a report with recommendations outside of the UN, the outside investigators, including somebody who used to work at CDC. And the recommendations were pretty dramatic. And so the UN has since convened a special committee to review the recommendations of the special committee. And I don't think their report has been released yet. But, I think that's appropriate. And I think that some of the measures they've recommended, for example, making sure that the sanitation conditions in any UN deployment are appropriate and proper and are not going to put anyone at risk for any sort of infectious diseases. That's quite appropriate. They've looked also at treating people who are being deployed who come from a country where cholera is endemic with a course of antibiotics before they even leave their country. There is a problem with that, and we can go into the problem if you'd like a little longer. And then they've also looked at vaccine. Should they vaccinate people? I don't think they've, as Mike said with HIV/AIDS, telling, for a country in Africa where cholera is endemic to say, oh no, we can't have any peacekeepers from Nepal here because, they've got cholera there, it sort of leads to an illogical, very visible process open to criticism, and I don't think we want to do that. That's part of the problem with antibiotics. We don't recommend, and I don't think any public health agency, WHO, CDC, UNICEF, or anybody with a medical background would recommend that everybody who's going anywhere from a country where there's cholera should take antibiotics before they go. Antibiotics and everything else is not without, harmful consequences. Maybe in a small group of people, but one of the consequences, it's just going to make the bugs more resistant. And there are others, there are health impacts on the people who take these. So those are difficult recommendations, because if you do it for UN peacekeepers, well, what about tourists? Why wouldn't Haiti say, good, I'm glad you did that, UN, and everybody coming to Haiti. All those NGOs you guys have to get a vaccine.
200,000 a year.
That's right. And it has to, and then, well, Haiti's doing that, why shouldn't all the other countries? And that's not compatible with what we believe is best practice for public health. So I think that's why it's taken them so long to think about it. But the bigger issue is not so much for cholera, but what about SARS, or diseases that are much more easily transmitted than cholera, much harder to prevent the transmission. I mean, safe water, a functioning toilet, that's pretty easy, but how do you stop somebody from spreading measles or respiratory illness? And what are the issues around that? And that's true for HIV/AIDS too. A lot of the HIV/AIDS work has been done with the military in many countries, trying to make sure that they're not part of the problem.
Well, thank you so much, and we hope that some of you will join us over in Bay 4 of Smith Warehouse at the Franklin Humanities Institute for the conversation with Sydney and Eric Mintz this afternoon at 4. So, thank you.
Thanks.